Welcome everyone, and thank you again for joining today's webinar, Chikungunya, a global threat. This is a very interestingly titled webinar because it is dedicated to understanding one of the world's most persistent and spreading viral diseases, chikungunya. Well, it's evolved from being a regional public health issue to becoming a global threat over the last few years. Its debilitating symptoms such as high fever, severe joint pain, and prolonged fatigue not only strain individual health, but also place an immense burden on the healthcare systems worldwide. And today we live in an era of global warming and rapid urbanization, which has contributed further to its spread, making awareness and prevention critical. We're here today with Dr.Areena Siddiqui. She's an expert in virology and epidemiology and public health, who will delve into the chikungunya's pathology, modes of transmission, and the global impact. We hope to provide everyone with a comprehensive understanding of this virus and equip you with actionable insights to help combat and manage chikungunya. Right. Over to you, Dr. Siddiqui. The forum is yours, ma'am.
A very good evening to all the members and all the participants who have joined here for this particular topic on chikungunya, a global threat. So with lot of chikungunya cases and dengue cases we all are seeing in day-to-day cases in our hospitals, it is very important to touch upon this topic, which is really becoming a very hot topic of the day, and also like the knowledge and awareness becomes an integral part of prevention. And I would like to congratulate the entire team of JMitra for organizing such such event, and on this very topic, which is chikungunya, and it's really becoming a global threat. So why it is becoming a global threat, that we will be discussing and that we will be going through in due course of time. So I would like to start with a case scenario. So here I'll present a case. A patient, 33-year-old male, presents to the OPD with sudden onset of fever, chills, and severe joint pain in the hands, feet, knees, and elbows. The patient also gives some non-specific signs and symptoms like headache, muscle pain, then rash on the arms and the legs. So these are the complaints which are generally we see in the cases which are coming to the OPDs, and also there are some cases which do get admitted to the hospital. So on examination, the temperature was 102 Fahrenheit. The joint examination was done and it revealed swelling, redness, tenderness in the affected joints. Rash were present on the entire arms and legs. So the first thing which would come to our mind, so we have to keep in our mind the differential diagnosis, and depending upon the season, we should be knowing the epidemiology, like what is the month and like what are the cases which we are getting in that particular time. So here I have presented some pictures of the person, the clinical features of the disease in the patients, where we will find the infection. So can we change on to the next slide? So this is the rashes which we can see. So initially, what should come to our mind, that is very important, because not only like chikungunya and dengue, but nowadays we are getting more of cases which are related to acute undifferentiated febrile illness. Acute, when the fever is there for more than 7 days, and still we have not reached to any diagnosis, then we say we classify it into acute undifferentiated febrile illness. So how we have to take the case? So we have to think something in mind, like these are my differential diagnosis, and to rule out we have these certain tests so that we can come to a particular diagnosis. So here the patient was having headache, myalgia, arthritis, rashes over the entire body, and also a high grade fever that was 102. So coming to the lab tests which were ordered, so the tests were IgM antibodies for chikungunya virus, then NS1 antigen, IgM and IgG for dengue, and chikungunya was sent. Complete blood count were ordered, and since the patient was having swollen joints, and then the RF factor, anti-CCP, and a malarial parasite test, these were the tests which were ordered for this particular patient. Then the differential diagnosis. So there are certain disease which present with the same kind of sign and symptoms, and depending on the endemicity or the epidemicity, we should be keeping these DDs in our mind and henceforth ordering the test. So dengue virus, we also have Zika virus infection which mimics very similar to chikungunya. So that is also very important, which has to be kept in mind for differential diagnosis of the patient. Then we also have the rheumatoid arthritis, and also there can be some other mosquito-borne illnesses where we do not get any test positive, but then still the patient will have these kind of sign and symptoms where everything is negative. So that also should be kept in mind. So for this patient, the chikungunya IgM antibodies were positive, and also a PCR was sent for chikungunya, which was later found out to be positive. And then the patient was then diagnosed as a case of chikungunya, and the patient was treated then accordingly. So coming to the chikungunya disease, what exactly is and where does it originate from? What was the, past history? So the origin of this chikungunya name, it is derived from the native language word that is Kimakonde. So Kimakonde is the word, and it is derived from Swahili word that is Kungunyala, which means to become contorted, where the body acquires a curved posture. The patient is not able to walk because of strong joint pains, and this is a very classic symptoms when it is a case of chikungunya. It is associated with very severe polyarthralgia, and it is associated with morbidity. So initially, the chikungunya virus, it was not reported much, and also the fatality was not associated with this chikungunya disease. But as we have seen so many outbreaks, and also with the resurgence of chikungunya viral disease, it is also associated with the mortality, and the mortality which is there which is associated with chikungunya is now 0.1%. So now slowly and slowly it is evolving from asymptomatic to symptomatic from one particular area. Initially it started in Africa, but now the entire world is grappling with this disease. It was isolated for the first time in African continent in Tanzania in 1953. Then later on, many countries also reported this disease, and in India it was reported after 10 years around in 1960s. So this is how it is being uh, uh, spreading very fast. So here we can see different colors in which is being depicted in this particular photograph, and this has been taken from European Center of Disease Control, where India has a little dark orange in color, which says that the mortality related to this is 10 to 99 per lakh persons. Next slide, please. Okay, so coming to the real world data, what is the prevalence of chikungunya in the entire world? So in July, August, and September, the 3-month data of 2024, it says that 460,000 cases of chikungunya virus disease were reported, and 170 chikungunya virus disease were associated with death. So these all data I have taken from European Center for Disease Control. And a total of 23 countries have reported this chikungunya viral cases. That is from America, Asia, Africa, Europe. Then Grenada reported chikungunya viral disease cases in September and for the first time in 2024. So we are seeing that slowly and slowly this virus is affecting the entire globe. So this was one report which I have taken. This was an article which was published on October 2024, and it says that alarming outbreaks in Lucknow and Pune, health camps cancelled. So what happening nowadays, we are getting more of dengue cases, more of chikungunya cases, and it is really very badly impacting the healthcare facilities in these cities. And it has also led to the cancellation of critical health camps and overwhelmed hospitals with a critical shortage of beds and the medical staff. So they are not able to cater the normal critical cases. So much cases we are reporting here in the Uttar Pradesh, especially in Lucknow and Pune. Next slide, please. So this was one paper which was published in the Lancet Microbe 2021, that is seroprevalence of chikungunya viral infection in India 2017. This was a cross-sectional population-based survey. And in this survey, what they have stated that yes, at that particular time, the chikungunya viral transmission was more in southern, western, and the northern regions. So this paper says though the transmission was higher in the southern, western, northern regions of India, when it is compared to the eastern and the northeastern regions of India, a higher proportion of the population is susceptible to the chikungunya virus in this particular region. And this shows that this particular region can also give rise to outbreaks in the future. So this survey findings, what they are concluding, that this study will be useful in identifying the target age groups and sites for setting up surveillance and also for future vaccine trials. We know that there are so much vaccine trials going on, but still we are yet to find a good vaccine. So this paper was all about. So chikungunya is basically a vector-borne disease, and it has multiple strains or lineages that differ in their RNA sequences. That is West African, East Central, South African strain, Asian strain, and Indian Ocean lineages. So these are the 4 strains which are very, very commonly found. And according to their geographical distribution, in the urban areas, they act as the major host for chikungunya virus, and the virus is primarily transmitted by the mosquitoes, Aedes aegypti and Aedes albopictus. So these are the mosquitoes. These species, we should also remember that they are responsible for dengue virus transmission, and at the same time, they are also responsible for this chikungunya virus. So I would also like to add upon that initially the chikungunya virus was thought as a part of the dengue virus, but later on research were done and it was found no, that the family is different, and also this is though the vector is same, but the disease is totally different. So it is, as I told, that initially it was in one, it started in 1950 from Africa, and slowly it is spreading so fast. And also the one terminology, that is autochthonous transmission, is being used for this particular virus, because in Brazil there are cases where there were no environment, but still we got cases in the Brazil. That is why the autochthonous transmission is very important in this particular virus, and therefore we say that it is emerging arboviral infection, and it is alpha virus, which belongs to Toga viridae family, and it is associated with high degree of morbidity. severe and they take a chronic form, that the patient is really not able to walk properly, and then he take absenteeism from his work. So this is the like consequences once a person gets infection. So transmission is generally by mosquitoes, but also rarely the reports are there that the blood transfusions are also associated, and also there are some rare cases of vertical transmission where the from the mother to the baby the transmission of infection has been reported. The morbidity is generally associated because of arthralgia, and it is arthritis generated. And also there are literatures which say that not only the muscles, but also there are cases, sometimes it can also lead to severe cardiovascular involvement, and also it can lead to neurological manifestations, like for example myocarditis. And in neurological there are reports where Guillain-Barré syndrome has also been reported after the chikungunya viral infection. Once the patient gets infection, the disease onset is after a week, and it ranges from 2 to 12 days after the bite. It is characterized by abrupt onset of fever, accompanied by joint pain, and also we can see rashes. So generally it is a triad of fever, high grade fever, the joint pain, and the rashes. And pain is very debilitating. It can be for few days, but it can prolong for a longer duration, maybe weeks or months, or sometimes it can be years. There are cases where the chikungunya, the pain, the joint pain has been reported for more than 2 years. Then other symptoms which are associated with this disease is joint swelling, muscle pain, headache, nausea, fatigue. And these symptoms overlap with other infections. As I discussed that in my differential diagnosis slide, that yes, dengue virus and Zika virus, they do report with these kind of symptoms, and there many a times if the testing is not performed, then it can be misdiagnosed. So testing is very important. Here lies the importance of testing. Next slide. Okay. So this is one paper. This was published as a systematic review in the Tropical Medicine and Infectious Disease. And the paper was on epidemiology and economic burden of chikungunya. This was a literature review. And it says that the impact of chikungunya disease is very high, leading to absenteeism and economic cost, mainly due to its extraordinary epidemic potential and associated joint pain, which can be very severe and disabling. So we know that whenever there is disease, there can be some morbidity, and also the disease is related to mortality, as we know that even the bacterial infections are associated with morbidity and mortality. Similarly, this chikungunya virus disease is also related to morbidity, and it leads to absenteeism, and also also affects the economy of that particular country. Next slide. So this is again a paper which was published in the London School of Hygiene and Tropical Medicine in 2024. And it says that risk of death from chikungunya continues for up to 3 months. So they have analyzed cases, like 50,000 cases. And the paper says that yes, these patients, they might need extended healthcare support once they get chikungunya viral disease. Next slide, please. So they have analyzed 1.5 lakh cases of chikungunya infections, and the data which they have taken, this London School of Hygiene and Tropical Medicine data they have taken from 100 million Brazilian cohort. And these findings show that people infected with the virus are at risk from complications even after the period of acute infection ends. So that is very important when when the patient recovers from the viremic phase, when the antigenemia phase, then also the virus is still active, and it has the capacity to cause further complications. So in the first week, the infected individuals were 8 times more likely to die than unexposed individuals. And they were still twice as likely to die from complications at 3 months post-infection. So even after 3 months, even when the symptoms has subsided, then too this viral disease is associated with mortality and other complications after 3 months of infection. So the authors also conclude that patients had an increased risk of death through cardiovascular conditions. This is rare condition which is associated with chikungunya viral disease, for example, ischemic heart disease. It was also associated with metabolic and kidney diseases, and it was not at all associated with age group and sex. So this was the finding which was published in this particular study. Then coming to the another study, this was published in the Lancet Infectious Disease, and this was on chikungunya virus, an update on the biology and pathogenesis of this emerging pathogen. So this was an article which says the chikungunya fever can present with a varied clinical picture. That is, about 3 to 25% of people are still asymptomatic. They do not have any kind of symptoms, and then too they are having the chikungunya disease. So this is all about this paper which was published. Next. Okay. And yes, this is one paper. This picture was very beautifully, this is very beautiful photograph which shows like once the mosquito bites, so the skin is there, mosquito is sitting over the skin and mosquito is ready to bite. And once it bites, so there are some smaller cells which are there present in the skin. So in these cells, they then take the virus and then they try to eliminate. So these are the macrophages and the cutaneous fibroblasts which are there in the skin. So once the virus enters, these are then taken up by these cells. And then the nearest lymph node, you can see at the center of this photograph, there is a lymph node which is trying to eliminate the virus, but you can also see that there are arrows. So once the virus enters in the lymph node, then this can cause infection to these various organs. So we have joints, the muscle, then also it is affecting eye, brain, heart, kidney, liver, and through placenta, it is also reaching the fetus. So this is a very beautiful like diagram where the virus is introduced in the skin by the bite of the infected mosquito, initiates replication in macrophages and cutaneous fibroblasts. Then virus particles are here captured by the dendritic cells from the skin, and then it is carried to the lymph node. From the lymph node, they infect other areas, and these are the various organs which get affected with the chikungunya. This is why we see the symptoms even after the virus get clears, because they have the infection in these organs. Next slide, please. Okay, so this is another paper. This is from Journal of Clinical Virology. It was published in 2009, and this was on systemic involvements and fatalities during chikungunya epidemic in India 2006. So we all know that India saw an epidemic of chikungunya in 2006, and this paper says that besides the high fever, that is 39 degrees centigrade, rash, arthralgia, the other symptoms which were present during that particular epidemic, the people also had headache, they had photophobia and the swelling and conjunctivitis. And also, though in that time when it associated with severe neurological, cardiovascular, and hemorrhagic manifestations. So besides the local and non-specific sign symptoms, this is paper which says that yes, the people were also having the neurological and cardiovascular complications. Next slide. Okay, So it says that 40% of the patient, they present with the IgM, anti-IgM against chikungunya virus. And though we say that IgM is not present after 2 months or so, but here they found that even after 18 months after the onset of the disease, the IgM was present, and this proves the high chronic potential of the infection. Also, the cases do present arthritis after many years of infection, and they also have exacerbation of the disease which is present after the infections. The rash may be of maculopapular or petechial type, but in many cases it's more than 90% of the skin surface, and it disappears 3 to 4 days afterwards. Next slide. Okay. So here, I would like to present a case. So this was a case report which was published in infectious disease cases in 2017. And in this case, what they have tried to tell that there can be chikungunya and dengue virus co-infection. So the title of this report was dengue virus serotype 3 and chikungunya virus co-infection in a traveler returning from India to Portugal, November 2016. Next slide. So in this, what they have mentioned, there was a 65-year-old Portuguese woman. She came to India from Portuguese, and then she traveled to many places, Mumbai, Rishikesh, Delhi, and she traveled so many places. And then at the end, she reported to the OPD with the complaint of fever, myalgia, retroorbital pain, pruritus, and subtle rash under tan skin. The patient denied of any nausea, vomiting, or any abdominal distress. She recounts having had 3 days of high-grade fever of 39-40 degrees centigrade, intense myalgia and retroorbital pain. And initially, when she went to the OPD, she was diagnosed as a case of urinary tract infection, and she was given treatment, and the tests were performed that showed leukocytes and bacteria in the urine routine microscopy. And at that time, the test which were done was for dengue, NS1 antigen, IgM and IgG for dengue virus and Plasmodium species immunochromatographic test. And she was treated with antimicrobials because at that time it was found that she's having UTI, and was apyretic after 4 days. Then after that, she left from India, and then she landed in her country. There, her symptoms again, like for 3-4 days, the infections were abated, but then again she had some signs and symptoms, and then she was admitted in Portugal. So patient was febrile at the time of admission. The blood test showed lymphopenia, and there were no any abnormal CBC picture. The CRP protein was not elevated, and at that time the liver enzymes were normal. So after 24 hours, the patient had peripheral edema, and on pulmonary auscultation, some crackles were found. Then she showed slowed psychomotor functioning, and drowsiness was noted, along with leukopenia and anemia. Then 3 blood smears were again sent for Plasmodium species, which was negative again this time. Then serological test for HIV 1 and 2, and hepatitis B, hepatitis C virus, HIV, IgM, and VDRL, TPHA. They all were sent to the lab, but they all were negative. Echocardiography and chest X-ray did not reveal any significant findings. So the second time when she was admitted, nothing could be deduced from the findings laboratory reports. The treatment was continued. Then laboratory findings showed maintenance of low values for CRP, negative PCT, then new onset of thrombocytopenia with 56,000 platelets. Now the CBC picture was little bit deranged and there was a thrombocytopenia. The LFT also, the SGPT, SGOT, it was very high and it was tested. Patient was treated and discharged after a week. Then again, when the patient came after 2 weeks, the patient now complained of joint pain with arthralgia, and she was not able to maintain her gait. Now the test was sent to National Vector-Borne Institute, that is their reference laboratory, which is there in Portugal, and then the tests were done for dengue and also back slide, please. Go to the previous slide. Okay, so the tests were done, and now the test for dengue was positive, serotype 3, and chikungunya was positive. So after I think 1 month of treatment, or after having the different diagnosis, the patient was now diagnosed with chikungunya disease and a co-infection of dengue virus. So this is the state of difficulties in diagnosing this particular disease, especially when the patient is coming from an area where the chikungunya virus and the dengue virus is so endemic, and she is going to Portugal. So in those countries, it becomes very difficult and to think on those lines and to get the diagnosis made. Then finally, diagnosis was made and the patient was given the treatment and some steroids, and the patient was treated finally. So the next slide, please. Okay, so we are diagnosing, but prevention is more important. As we know that currently the no specific treatment is present. The use of anti-inflammatory drugs for symptomatic relief is there. But what we can do, we can try to prevent, because once the chikungunya virus infection is there, though we are testing with IgM now, the PCR and also the CLIA is being used, and immunofluorescence assays, these diagnostic modalities are there. But still, once the disease has set in, we have to like prevent from complications. So why to reach till that stage? We should prevent the infection first. So how can we do the prevention? We can use insect repellent, wear long clothing during the time when the breeding season is there. So wear long clothing, treat clothing and gear with 0.5% of permethrin. Stay in air-conditioned lodging, like if suppose somebody is traveling, so choose a hotel or lodging with air conditioning or screens on windows and doors. And this mosquito, this is also very important. The same goes for dengue also. The breeding site should be removed as far as possible. So this is prevention becomes the key for preventing the disease. Coming to the next slide. Okay, so a lot has been done on the development of vaccines. So currently, only one chikungunya vaccine, that is the 9-chick, is available in the United States, and it is approved by US FDA. It was approved in November 2023, and later it was rolled out for the people who are working in laboratory, and also for the people who are traveling. For them, it was rolled out in February 2024, and it was manufactured by Valneva. And this is a live attenuated vaccine. A single dose of 0.5 ml is given intramuscularly, and there is no booster dose. Only single dose is sufficient, and it is approved for use in adults, that is 18 years and older. The sero response which is associated with this vaccine, as per CDC information, it says that the sero prevalence is 90 6% after 6 months of vaccination. So it is quite a good vaccine which can be given. The only thing is that it is like, since it is live attenuated vaccine, so it should not be given in the immunocompromised and also in pregnancy. So these are the conditions where we have to be very cautious. And yes. So chikungunya, back slide only, the vaccine slide, please. Yes, chikungunya vaccine should be considered for the adults who are traveling to a country or a territory without an outbreak, but there is evidence of chikungunya virus transmission among humans within the last 5 years. Person aged more than 65 years, particularly those with underlying medical conditions, or who are likely to have a moderate exposure or to mosquitoes should be given, and persons staying for a cumulative period of 6 months or more where the chikungunya virus disease is prevalent. So these are the candidates who this vaccine should be given, but still there are more candidature for the vaccine and more trials on polyvalent immunoglobulin. It is being going on, so maybe we can have more vaccines maybe in near future. So next slide. Okay, this is something which I would like to discuss, because in my past slides I told that yes, the person will be having chikungunya disease, but after 3 months or more than that, they will also have the feature of arthralgia or arthritis. So that particular term is known as chronic chikungunya arthritis, and long-term condition that can develop in up to 50% of people who have chikungunya fever. And symptoms of this include joint pain and joint swelling, which is very severe and debilitating, and it can affect multiple joints at a time and in a symmetrical pattern. The most common joints are of hand, wrist, ankles, metatarsal, phalangeal joints of the feet. The other symptoms which are associated with chikungunya and which occur after 3 months is fatigue, muscle pain, headache, nausea, insomnia, morning stiffness, and this is generally confused with rheumatic arthritis, memory or concentration problems, and depressions. The inflammatory markers such as ESR and CRP are usually elevated during this time. Some patients can also have radiographic evidence of joint damage. So the osteoclast cells and the cells, they lead to joint damage. So this is associated with chronic chikungunya arthritis. Okay. So it is similar to rheumatoid arthritis. Like the patients with CCA, they are middle-aged and are women. Some patients have positive rheumatoid factor. Some patients have positive anti-cyclic citrullinated peptide antibody test results. So this is very similar. So a very proper history of the patient, exposure history, or a patient traveling history, whether it's coming from the endemic area or from an area where the exposure is there. This is very important. As we all know, treatment is we don't have any specific treatment per se, which is very symptomatic. We can have some paracetamol. If it is not like resolving, then we can later have some steroids. But when the patient is having R factor positive or anti-CCP positive, then also the physicians do give the arthritis, rheumatoid, when the patient is suffering with rheumatoid arthritis. So those drugs also can be given, and those drugs are very useful. So I would like to say that prevention is better than cure. We should go for prevention. And once the chikungunya is there, the early diagnostic modalities should be sought by the consultant IgM, though IgM is there, but yes, we have some other technologies. The PCR is there, which can detect the antigen, and in no time, I mean, the antibody take 1 week to 10 days to develop. So we have other tests, other modalities which can tell us that yes, the patient is suffering with this viral disease, and also we can take some action so that we can reduce the severity on the complications. So I think that was all for chikungunya viral disease. Thank you for the patient listening to all the listeners.
Thank you, ma'am. First, thank you very much for taking out the time to, bring this into focus and highlight a disease which can be confusing to many people, very honestly. Chikungunya, like you said, with its symptoms and arthritis, joint pains, we sometimes don't look at the obvious. We just, people have, not all diagnostic techniques have reached everywhere. Not all vaccines have reached everywhere. In your opinion, ma'am, especially with the chikungunya vaccine that we talked about, that in fact you talked about, it's available in the US, where the
Yes,
prevalence is not really, it's more of a preventive thing because you want to make sure that people traveling from the US to certain areas where vector-borne diseases are prevalent, like tropical nations, it's like a prevention thing. But how effective do you think it would be in the Indian scenario? Because we are the ones who actually suffer from dengue and chikungunya. And while they both have the same carrier, as in the mosquito, the vector, but their epidemiology is very different from one another. So do you think that if India has that vaccine, it will have an impact in the Indian subcontinent? Because all vaccines are different and they can be a
Yeah,
geographical
vaccines
change.
are different, and also we need to find out the serotypes which are prevalent in our scenario. What are the serotypes which are prevalent? Because they have the vaccine, and against which strain they have made, that also we need to know. And that is why we say diagnostic is very much important, because in one publication which I just shared, they say that though they have found that the cases are there in the other parts, but in the eastern parts still, like the cases were not there, but still we have the virus can go there and cause infections. So more, if we report more and more case, so maybe that will help in studying some suppose we have the real patient, or what is the prevalence rate exactly. And here comes the role of diagnostic facilities. Generally, if the patient is coming and many times we don't test and we say okay, because we know that there is no such definite treatment, it is all symptomatic, and we just treat the patient. We ask them to have plenty of fluids and take rest. We monitor the platelets, and when the patient is okay, then this is all we are doing. Not everybody is going for the lab diagnosis, but here comes the importance of lab diagnosis, because the more and more diagnosis we'll do, the more number of data for this particular disease we'll get, and we'll be having some way, like where exactly we have to go, what is the vaccine, what kind of vaccine is required. So we need to work on this, for to get more data, to know what will be beneficial for our Indian population, whether that particular vaccine is helpful or not. So this is, still required, I think.
Yes, because I think it's ironical that the countries where you have tropical diseases, they don't have the vaccines for those particular
Yes.
diseases. And it is in the West where they don't have those diseases, whether it's dengue, whether it's malaria or chikungunya, that they actually look at this and say, okay, let's find a vaccine for it. Of course, it costs a lot of money, I'm sure, to develop any kind of vaccine, to do the clinical trials. But if we take this up because we're talking about a global health phenomenon here, I think the authorities here need to take this up more strongly in terms of, like you said, prevention is better than a cure, right? So, and thank you very
But
much for your
yes,
time,
we
ma'am.
need data on that.
Just one question that I had, one last question was, the RT-PCR that we talked about, it's an antigen-based test. And like you have in dengue, you have an NS1 for antigen and the IgM and IgG for your antibody test. Would you recommend that people should, if you experience certain symptoms pertaining to chikungunya, that the PCR should be done, and a combination test of PCR, that is an antigen test with antibody test, would it be more useful in help in diagnosis of the disease?
I mean, a combination of chikungunya with dengue.
No, I'm saying a combination of
Ah.
chikungunya PCR, because right now there is no antigen test other than PCR. And if you wait for 7 days, you cross a certain timeline. So would you recommend that you do a PCR first, followed by an antibody test, or would you just wait for 7 days and go for an antibody test at present?
No, it would be better if we get the RT-PCR done. Again, the cost of this test would matter in Indian scenario, like what exactly would be the cost, because right now, even what I know that dengue also, we are emphasizing more on the ELISA testing, and RT-PCR is
I think ma'am is having some network issues. Yes, ma'am.
So definitely, I was saying that in dengue, though it is a epidemic, and every 3 years we are getting a lot of cases, but still we are not into so much RT-PCR testing. But if we come to know and like early, then yes, the treatment, then accordingly we can like tell the patient what all things he have to do's and don'ts to the patient. So it would be better if we get to know that yes, the patient is suffering, he will be it would be better for the patient also, they'll be taking rest, and similarly the things will improve faster.
Thank you very much for your time, ma'am. Thank you very much for your patience and lovely case study-based approach that you have when we've seen that in the past as well. We look forward to our next interaction, ma'am. Thank you for your time and effort, ma'am. Appreciate it.
Thank
Thank you, Govind. And
Thank you,
thank you,
ma'am.
ladies and gentlemen, for joining us today. We'll see you soon in the coming week after Diwali with a new webinar in our health series. Thank you.